Okay, so this week we're going to talk about some not only complications, but not maybe the normal labor that we talked about last class. So when things don't quite go as planned. So induction or augmentation. So last week we talked about when women go into labor on their own, and then the care for those women throughout those different phases of the labor process. So what if that doesn't happen? Induction is when we give some form of medication or do something in order to start that labor. And then augmentation would be we do something or give a medication to make that labor progress or a little bit faster. So the woman begins labor on her own, and we're just going to help her along a little bit. So that's augmentation. Different reasons: post-term pregnancy, dystocia, prolonged rupture of membranes, medical complications such as PIH or diabetes, and there's others also, fetal demise. The things we're going to do before we decide to induce a Bishop score. A Bishop score is going to tell us how successful that induction is likely to be. For first-time moms, we want that Bishop score to be a 9. For second-time moms or more, so for multips, a 5 or above, tells us that that induction will be successful more times than not versus if that score is lower. Different types. There's cervical ripening agents, which changes the cervix from a firm consistency to a soft consistency. Examples of those would be Cervidil or Cytotec. Important thing is sometimes that can cause the women to go completely into labor and deliver, but most of the time this just ripens the cervix in order to be able to start Pitocin. But you don't want to start the Pitocin until the ripening agent has been removed and several hours after that agent is removed, not immediately. Induction of labor is done by the synthetic form of oxytocin, which is called Pitocin. It's given IV, it's mixed with LR, and it's given in milliunits per minute. Piggybacked through a regular IV fluid. Started at a very low rate and increased, depending upon the doctor's order, usually every 15 to 30 minutes for induction purposes. Natural ways for labor induction would be sex or nipple stimulation. There's also some massage or acupressure points that may induce labor. And this is just a drug box on Pitocin. Pitocin is also used in the 4th stage of labor to prevent hemorrhage. It contracts the uterus down. You want to be on the lookout for uterine rupture, uterine hypertonicity. So if the uterine contracts too much, water intoxication, and hypertension. Continuous monitoring is required when Pitocin's in use, and I's and O's are also required. Signs of labor complications. This is not all of them. Dysfunctional labor, so contractions can be hypertonic or hypotonic. Hypotonic is they may not be strong enough to cause cervical dilation or may not last long enough. They can be caused by several different things: too much amniotic fluid, bowel or bladder distension. Hypertonic contractions is when there's an increase in uterine tone. And doesn't allow the uterus to contract in between. You might want to consider a tocolytic, but if mom has Pitocin running and she's a hypertonic uterus, make sure you stop the Pitocin first. A precipitous labor, usually these women go, or a precip means very fast, so usually less than 3 hours. A lot of these babies are born without the doctor or the caregiver present. The nurses are the ones catching these kiddos. Most of these deliveries go fairly easy. However, they're at greater risk a lot of times for postpartum hemorrhage, so that's why it's under labor complications. CPD is when the pelvis and the fetal head don't quite match up, so the baby does not fit out of mom's pelvis. Normally she will stop dilating, and on the monitor a lot of times you'll see those early decelerations, that fetal head pressure, and mom will not be making that fast progress that's normally seen with those easy decel or early decels. Fetal heart rate patterns, you'll see those late decels or variable decels could be signs of complications. You know, absent or minimal variability, no accelerations, tachycardia, bradycardia, all those that we've already talked about. And then vital signs, if mom's heart rate's too high, blood pressure too low, or vice versa, or signs and symptoms of shock. Also, another sign of a labor complication is meconium-stained fluid. So if mom's membranes rupture, you want to, first and foremost, if she's not on continuous monitoring, you want to check that fetal heart rate. Number two, you want to note the color. If it's not clear and it's meconium stained, that can be a sign of a complication, because at some point that baby lost that vagal down because lost control, because it could have had a lack of oxygen and had a bowel movement. So you check the fetal heart rate, because when that water breaks, that cord can come down in front of the presenting part and you can have a prolapsed cord. So confirm that the fetal heart rate is normal. Then if you have meconium stained fluid, you're going to consider what we call an amnio infusion. And what that does is that puts fluid back up around the baby, flushes that meconium out, and then there's less risk for aspiration when the baby's born. And there's a nice video on the YouTube page of amnio infusion. Different types of emergency malpresentations. If the baby's not positioned correctly to come out, you can see, you know, the heart rate problems and whatnot. Shoulder dystocia, the video clip that we watched a couple weeks ago was a shoulder dystocia, and you still have access to that video on your YouTube. Prolapse cord, again, sometimes that umbilical cord can come down in front of the presenting part and come down, and every time that fetal head or the contraction comes, that cord gets compressed. So what do we do about that? Well, first and foremost, you want to think about taking the pressure of the presenting part off of that umbilical cord. So if you put your hands into the cervix, put your fingers onto the presenting part and press up off to relieve that pressure off of the cord, okay? But once you're there, you're stuck there until they deliver the baby by emergency C-section. You know, put mom in Trendelenburg, that's going to relieve some of that pressure also. I think your book says knee-chest position, you know, to try to relieve that pressure also. If you see the cord actually hanging out of the vagina, you can wrap it in sterile saline gauze to keep it moist. Amniotic fluid embolism, true emergency. Mom is going to say, I can't breathe, turn blue, and you'll be doing CPR. Uterine ruptures, same thing. This is a true emergency. Mom's going to be bleeding out. You're at increased risk for uterine rupture if you've had a previous cesarean section, especially if it's a vertical, classical, straight up and down incision. Chorio is infection of the amniotic fluid. You're at increased risk for chorio if your membranes have been ruptured for greater than 24 hours. Retained placenta, you're increased risk for hemorrhage. Here's a picture of a prolapsed cord. Possible interventions. Episiotomy, laceration, we've already talked briefly about that. Those, forceps and vacuum. You know, if mom's having trouble pushing that baby out and we need to get it out quicker, we can use either or. And usually it's doctor preference. Aversion. Aversion is if baby is not positioned correctly, they can externally, there's an external and internal version. But they can externally kind of do a very aggressive Leopold's maneuvers type and try to turn the baby. Internally, they can go in vaginally and try to turn the baby. Both can be very painful, and there are risks to the procedures also. And I'll let you read about that in your book and in ATI. And then, of course, you can do a cesarean section. Cesarean section rate in 1970 was 5.5%. Currently, it's 30% or higher, depending upon what hospital. Here's a picture of forceps. Picture of a vacuum. So talking a little bit about C-sections. Obviously, they're different if they're scheduled versus emergent. If it is an emergent C-section, you just get there as quickly as possible. You get verbal consent and you go. A lot more anxious for the patient. She doesn't get nearly the amount of education and whatnot as a scheduled cesarean. Scheduled, you want to educate. She's going to get lab work done a couple of days ahead of time. You're going to start an IV. You're going to give a fluid bolus. You are going to put TED hose on, STDs on. You're going to prep her skin. You may clip the top portion of her pubic hair, depending upon doctor preference. You're going to take her to the OR. You're going to keep her warm. She's going to have her spinal done. Then she's going to lay back. You're going to prep her skin. You're going to put her Foley in after she's nice and numb. And then of course, the whole procedure from start to finish takes about an hour, but the baby's out in about the first 5 minutes. They're going to do the horizontal bikini cut. Recovery. Same as far as check every 15 minutes type thing, but mom's going to have an IV longer. She's going to have a Foley catheter until the next day. She's going to be numb for a couple hours, and she's probably going to be a lot more sore. You're going to encourage splinting the stomach. When coughing and deep breathing, because that's important to not get pneumonia. Walk as soon as possible to prevent those blood clots. VBAC is vaginal birth after cesarean section, and that is possible if you have had a previous horizontal incision on the uterus, and if your doctor is okay with attempting that. If you've had a vertical or a classical incision on your uterus, they will not let you attempt the vaginal birth after cesarean because you're at very high risk of a uterine rupture. Here are some drugs that may result in complications of after surgery. And here's just a picture of the different incisions. Again, this is a vertical classical incision. Okay, and then this is what they try to use, horizontal bikini cut. Most of the time, you will not see a classical vertical incision unless, nowadays, unless the baby is transverse and they can't get it out the other way, or if it's a true emergency, just because it's quicker. Fourth stage of labor, we've already talked about on other weeks, and this is just the recovery time. Vital signs, fundus, bleeding, everything you do every 15 minutes. Assist with breastfeeding, educate the mom, promote bonding, skin to skin, peri-care, make sure the mom's voiding, all that good stuff. So postpartum physiological changes, so we're moving from delivery, recovery, now we're in the postpartum period. The breast milk does not come in until about day 3 postpartum, so we need to educate moms on this because when moms deliver and they don't see breast milk, sometimes they get concerned. So really educate moms. An hour after delivery, the fundus should be right about around the umbilicus and then decrease 1 finger width per day. Lochia takes 6 weeks. Until the implantation of the placenta site has healed. So the first 3 days you should see mainly rubra, which is mostly blood and small pieces, mucus red. Then over the next 3 to 10 days you'll see like a pinkish, kind of pink lemonade color. It's called serosa. And then around the 10th day, it decreases to a yellow or a white discharge called alba. If your discharge changes, it's been rubra, serosa, alba, and then it goes back to rubra, that is a danger sign or a sign of a complication that you want to report. Perineum remains swollen and tender. Urinary, moms have diuresis for day 2 to 5, and they'll void up to 3,000 mLs per day. Vital signs, never take a rectal temp for the first 24 hours. A temperature of 100.4 after the first 24 hours is considered febrile. So before the first 24 hours, you're good with a slight temperature because of the stress the body's been through. But after the 24 hours, 100.4, above 100.4 is actually defined as a temperature. Labs, you will see a decrease in hemoglobin because of the blood loss in delivery. Increased white blood cell count is normal. So think about how else would we monitor for infection for postpartum moms. Psychological changes, these are always fun. Taking in, taking hold, letting go. These are the phases. So the taking in phase is the dependent phase. A lot of times this is where they are when they're in the hospital. So day 1 or 2, first 24 to 48 hours, they're very dependent. They let the nurse do everything. Okay, that's normal. Now don't think about your personal situation and say, well, day 2 I was changing diapers and changing my own pad and whatnot. If she's still depending on the nurse to do everything on day 2, that's still considered normal per textbook. Okay. Taking hold, dependent and independent, initiates action, takes strong interest in the child but feels insecure for caring for them, and this can be day 2 to 3 and can last up to several weeks. Letting go, they become independent and they redefine their new role. Postpartum blues, around 50% of women feel overwhelmed, burst into tears, and this is due to hormonal fluctuations, a decrease in estrogen and progesterone. There is a difference in between postpartum blues and postpartum depression, and there is a nice separate information on postpartum depression located in Blackboard, along with a nice quick Jeopardy game you can play to test your knowledge on postpartum depression. Sibling visitations encouraged in postpartum to create that bonding, also rooming in with the baby. Postpartum assessment, there's one video for you to watch, but this is a focused postpartum assessment. B being breast, uterus, so you massage the top of the uterus being the fundus. You want it firm and midline, depending upon what day postpartum they are, around the umbilicus or 1 or 2 finger widths below. If it's deviated to one side or the other, the bladder's full. Bowel and bladder, lochia, the bleeding, and then this could be episiotomy, so you want to roll mom over and look at her laceration or episiotomy and also check for hemorrhoids. You also want to look for edema and pay attention to her vital signs. Here's a picture of where the fundus might be located and when. Here's the technique of palpating the fundus. You want to support the bladder and find the fundus. Here's your characteristics of lochia and what day you should see that color. Postpartum care, what are we going to do? Okay, so they're not just there so they can hang out and us do nothing but rock their babies, right? So we are there for a reason. We promote comfort measures, okay? So ice to the perineum for the first 12 to 24 hours and then sitz baths. Medications as needed. Muscular aches, Tylenol is best. Cramping, Motrin is best. Assess for DVTs. Teach them how to do Kegel exercises if they don't already know how to do it. Teach them to clean from front to back after each void. Teach them no co-sleeping with the baby. Make sure they're drinking plenty of fluid. If they get constipated, they can take a stool softener, but encourage plenty of water and high fiber foods and exercise first. Hemorrhoids, they can use sitz baths, stool softeners, Tux pads, or hemorrhoid cream. They're at increased risk for DVTs from the pregnancy, so make sure they know if they get swelling or edema or redness in their calves, that they let their doctor know. For breast engorgement, a sperm supportive bra. Discharge teaching, make sure they return in 4 to 6 weeks for their follow-up appointment. Make sure they get their MMR vaccine before discharge if they're not rubella immune. Make sure they get their RhoGAM if needed. So if they were A negative or they're negative and the baby is positive. Make sure they get their verbal and written instructions from their MD and the pediatrician, and make sure you provide a follow-up phone call to make sure everything's going okay. And then there's a lot of postpartum education that we provide throughout their stay. Complications. Infections. There's several different types of infections. I want to specifically mention mastitis, which is infection of the breast, and it's usually unilateral. If it's not treated, it may abscess. It usually occurs 2 to 4 weeks after delivery. Very, very painful. Sometimes these moms will be admitted back in. We do a lot of teaching as far as how to feed the baby with this, cleaning the breast before, making sure it stays clean. They're on antibiotics, and a lot of times pain meds to take care of the discomfort. Hemorrhage. If you see bleeding, okay, and you're wondering, is this too much? First and foremost, ask the lady, how long have you had this pad on? Okay? Second, you want to assess the fundus. So start massaging that fundus, okay? For a normal vaginal delivery, above 500 mLs, blood loss is considered a hemorrhage, and for a C-section, it's above 1,000 mLs. Risk factors for hemorrhage are on page 265 through 274 in your ATI book. And they list them, and it almost looks like they're separate things. So there's hemorrhage, and then that uterine atony, lacerations, hematoma, uterine inversions, uterine subinvolution, and retained placenta. All of those are risk factors for hemorrhage. So if any of those things occur, then they cause too much bleeding. So I hope that makes sense. So we've already assessed the fundus, and you can continually assess the fundus. Keep massaging it, okay? Try to get those clots out. Try to get that uterus firmed up. Is it midline, okay? If it's not midline and that mom has not peed recently, try to have her pee. If she can't pee, then get an order to straight cath her, empty that bladder. Because if that bladder's in the way, that uterus cannot contract down, so she's going to bleed more. So make sure her bladder's empty. If you have meds ordered for a hemorrhage, you're going to see most likely Pitocin IV, because that contracts the uterus down. Methergin is given IM. Before you give Methergin, you want to make sure mom is not hypertensive, because it's a contraindication. However, if mom's hemorrhaging, most likely her blood pressure is going to be low, not high. However, sometimes they will order a dose of Methergin and then give Methergin Q 6 hours. If that's the case, you want to make sure, like 6 hours from now, when mom's not bleeding so heavily, that she doesn't turn around and become hypertensive. And if she does, you want to withhold the medicine. Cytotec can be given for hemorrhage. So Cytotec is a cervical ripening agent for induction. So for that, you put it in the vagina. For hemorrhage purposes, it's put in the rectum at a much higher dose. Hemabate. Hemabate is given IM, and it's contraindicated with a history of asthma, and it causes severe diarrhea. Severe. The patient patient will poop all over you. DVT, how do we prevent them? Walk early and frequently, elevate legs when setting, increase fluid intake, recommend no smoking, TED hose. That's just to mention a few things. But how do we manage it if the patient already has it? Bed rest. Elevate legs above the heart, warm compresses to the legs, don't massage the limb, measure leg circumference, NSAIDs, anticoagulants, being heparin IV for 5 to 7 days, and then Coumadin for 3 months. So the difference in between preventing and managing. DIC, make sure you treat the underlying cause. So the body's platelets are going to rush to the site of injury. So say the mom has an abruption. So mom's platelets that are floating around in her body are all going to rush to that site of the abruption to try to clot off that extensive bleeding. And when they do that, then all the rest of the body are lacking those fibrinogen levels and platelets. So the rest of her body is unable to clot, and she tends to start bleeding out everywhere else. Treat the underlying cause, and then something strange for DIC that most students have a hard time understanding is these moms will get heparin. So you have a mom bleeding out, but yet you give heparin. And that's because you want to try to break up that cascade of platelet aggregation at that site of injury so they will spread out into the rest of the body. And this is just conditions that increase a risk for postpartum infection. Picture of some different causes of hemorrhage. Here's your degree of lacerations that we've already demonstrated. So perinatal loss is always hard for students to talk about. And I just plugged it in here since we're talking about complications with labor and postpartum. So it's going to, number one, the cause. What we may not know the exact cause, but did it happen before the mom got to the hospital or in the hospital? Was it possibly genetic, or was it a trauma accident? You know, you want to, if you're in the process of diagnosing, if you are trying to get a fetal heart rate, you know, you may give the mom an idea like, I am unable to find a fetal heart rate, but you're not actually able to diagnose and say, you know, your baby has passed away. You let the caregiver do that. Nurse's role is to support. Most families want to see and hold the baby. Some want pictures. Clean the baby, wrap it up in an infant blanket. They can remain with the parents as long as they want. Most of the time the hospitals provide a little box with pictures and a lock of hair, a card, and then depending upon how old the baby is, you know, there's different forms that need to be filled out. Allow the woman to talk and vent. Avoid phrases such as God knows best, or one door closes, another one opens. Provide privacy, and offer rooms off of the maternity ward. If mom, you know, has trouble hearing the baby's cry or whatnot, offer her a room elsewhere in the hospital. And these questions are available on your PowerPoint. So that's it for the lecture this week.